All right, good morning, everybody. It's 7:30, so we're going to get started. And actually, Dr. Sadai, can you minimize that Teams screen? I'm not sure why it keeps popping up for you. There you go. Great. And you can unmute your mic, so you'll be ready to speak. But good morning, everybody, and welcome to Pediatric Grand Rounds. Thank you for attending. As a reminder, please mute your devices as you log in. Questions will be saved for the end, and the participation code will be placed in the chat periodically. But let's give a warm welcome to Dr. Rupa Sadaya, who is currently an associate professor of pediatrics in the Division of Pediatric Pulmonology, Cystic Fibrosis, and Sleep Medicine. And she's the director of the Severe BPD Multidisciplinary Program at Penn State Health Children's Hospital. Dr. Sadaya started her research and clinical career at Penn State Health Hershey Medical Center soon after her fellowship, and since then she has focused her interest on extreme preterm infants with severe lung disease and pulmonary hypertension. She is the founder and director of the BPD Multidisciplinary Program to provide comprehensive inpatient and outpatient care. She is also the site director for the BPD Collaborative, an international collaborative of centers geared to improve quality of care for infants with severe BPD. To further care for these preterm infants and their outcomes, she is invested in translational research to identify non-invasive biomarkers for early identification of high-risk infants. Dr. Sadaya has received multiple awards, including the Eunice Kennedy Shriver National Institute of Child Health and Human Development Research Career Development Award and the 2022 Pulmonary Hypertension Association Early Career Mentored Scientist Award. So ladies and gentlemen, please welcome Dr. Sadaya.
Thank you very much for the kind introduction, Dr. Ranch, and good morning, everyone. Thank you for joining me today, and especially want to thank you, Dr. Seidner, for inviting me to give the talk and the opportunity to be here. So today we are going to talk a little bit about management of severe BPD and some newer guidelines and approach. I have no financial disclosures. Our learning objective for today would be to review different clinical phenotypes of patients with BPD and to discuss management of established severe BPD and to understand the role of multidisciplinary care in children with severe BPD. As we are all aware, with the recent advance in neonatal care, there is improved survival of extremely premature babies. And this has led to increased complications such as bronchopulmonary dysplasia or chronic lung disease of prematurity, and also one of the more severe complications known as pulmonary hypertension. So as you're all aware, during our embryologic phase, we have the around 24 to 26 weeks is our canalicular to saccular phase transition, and babies born at this gestational age do not have a fully developed or matured terminal bronchioles or alveoli. And when Dr. Northway defined BPD back in 1967, he described this as a chronic lung disease of premature infants with progressive emphysema and fibrosis associated with mechanical ventilation and oxidative stress. And at that time, the patient population that were born were relatively later on, like around 32 to 34 weeks of gestation. But as we saw much younger babies who started surviving, especially with the surfactant use, there was a revision to this where Alan Job defined this in 1998 as infants who were born between 23 to 26 weeks of gestation had arrested lung vascular and alveolar growth. So there was a transition from fibrosis and emphysematous changes to more of arrested growth of the alveoli and the blood vessels. In 2001, this is the most commonly used BPD definition, where Alan Job and Bankalari classified this into mild, moderate, and severe BPD, which I'm not going to go into detail since you're all pretty familiar with this. However, this definition has seen many more attempt at revising this definition has gone on, and the most recent one we have is from 2019 by Jensen et al., where they described any respiratory support at 36 weeks, irrespective of prior duration or current level of oxygen therapy. Was then categorized into grade 1 if they needed any oxygen flow through nasal cannula, but less than 22 liters per minute, and grade 2 nasal cannula at flow rates greater than 2 liters per minute, or invasive positive pressure ventilation, or non-invasive, and then grade 3 as invasive mechanical ventilation. So there have been many different definitions, but we still have significant limitation because these definitions are defined by the therapy. So based on what we are managing these patients with, but not necessarily based on the underlying pathophysiology. And also, what is happening is we are pooling all the premature babies at one time point for the sake of the definition at 36 weeks. So we are taking the babies who are born at 32 weeks and also babies who are born at 23 weeks and piling them all in one under one umbrella. While the pathophysiology can be very different between these babies based on the management. And also there is variable lung physiology. So we definitely need a more robust way of defining BPD. Nationally, incidence of BPD is variable. However, it's usually reported around 16% in those less than 32 weeks of gestation. But those who are born at less than 28, it can go up to 40 to 45%. Approximately around 15,000 new patients develop BPD in United States annually, and close to 2,000 infants have severe BPD and need mechanical ventilation at home. And the pathophysiology is highly complex because there are factors that are antenatally that can affect development of BPD, and then perinatal factors. Fetal, prior to conception or, soon after conception, pregnancy abnormalities and exposure of fetal to antenatal factors can modulate development of BPD. And soon after birth, there is injury in the initial phase when there is acute injury followed by repair. That can also predispose to development of BPD. And over the time, what we start defining as BPD around 36 weeks is when we start noticing the healing and remodeling phase of this lung development. So in a nutshell, we have multiple factors: intrauterine growth restriction, antenatal factors such as chorioamnionitis, maternal hypertension, genetic and epigenetic factors, postnatal nutritional impairment, PDA, oxygen toxicity, ventilator-induced lung injury, and postnatal infection, all of which can lead to one big umbrella we call BPD, which again can have different phenotypes based on what are the drivers for this pathology. When we talk about BPD, we spoke about what Dr. Northway had described earlier on, where there was significant lung injury with parenchymal fibrosis due to mechanical ventilation and oxygen toxicity. And then we have a newer definition now with improved modes of ventilation and increased use of surfactant use, where we have arrested growth. We don't have so much inflammatory changes, but we have simplified alveoli and also sparse pulmonary vascular development. Does it mean we don't see the fibrotic changes and cystic changes that was described as old BPD? Not necessarily. We still continue to see the fibrotic changes in extremely severe BPD, where we have a combination of alveolar simplification and delayed vascular growth combined with areas of fibrosis and cystic changes. And they can also have pretty significant pulmonary vascular disease on top of small and large airway injury. So this is a schema to again highlight the development of the alveoli and pulmonary vasculature in the premature infants in the new BPD, where there are simplified alveoli and also blood vessels. And in this image, we can see what we call pruning of the pulmonary vasculature, where we don't have as many vascular structures as you would see in a normal infant. And this is again a 3D reconstruction of the pulmonary vasculature highlighting the pruning. Catherine Wu et al. From CHOP did this very good study looking at the clinical to define clinical phenotypes of severe BPD. So they did on a cohort of severe BPD patients, they did CT scans, they performed bronchoscopy and also cardiac catheterization. And 1/3 of these patients with severe BPD had a significant overlap of all these three phenotypes. And as you can see in this particular population, there were like half of them, over half of 50% of them had pulmonary vascular disease too. The clinical features of BPD is variable. Mostly they do present with hypoxemia, tachypnea. They have increased work of breathing, but they can also present with just poor growth. When we talk about evaluation, while clinical features is the way to diagnose, sometimes looking at the blood gas, which shows hypoxia, hypercarbia, and respiratory acidosis can also be the hallmark, especially in acute pulmonary exacerbation of BPD. Chest x-rays can show hypoventilation or hyperventilation. Areas of atelectasis, also migratory atelectasis, and sometimes pulmonary edema and PIE. And here I have two x-rays of very different appearing BPDs. On the right-hand side, we have more cystic and fibrotic, what we classify as more severe BPD changes. On the right-hand side is an X-ray of a patient with a more milder disease or more simplified disease where we don't see as much fibrosis, but it is consistent with alveolar and pulmonary vascular simplification. In some cases, a CT scan would be warranted, especially if there is suspicion for surfactant protein deficiency or if there is concern for interstitial lung disease associated with BPD. And we noticed that the CT scan has much more granular information compared to what a chest X-ray can show us, even in terms of the severity of the lung disease in itself. So that can be helpful sometimes. Bronchoscopy would be helpful to evaluate for airway disease, which we will talk about in a few minutes. And echocardiogram helps us in screening for pulmonary vascular pathology. And if there is a concern for aspiration, a swallow evaluation would be important. Moving on to management of BPD, the 5 main strategies is to avoid infections, to avoid pulmonary hypertensive crisis, and optimizing growth, which is the most important of those, and provide intensive developmental care while minimizing the impact of the respiratory support. When we talk about the large airway disease, because of the significant the traction and stress that the airways go through while the airways are not fully developed and the cartilage is not matured enough, they are at high risk for developing tracheomalacia and also bronchomalacia. When there is any incidence of airway manipulation, such as intubation or prolonged recurrent intubations, they are also at risk for developing subglottic stenosis or tracheal stenosis. We often sometimes see granulomas developing at the cords or in the subglottic region. And sometimes this picture can be confounded with a coincidence of complete cartilage tracheal rings or tracheoesophageal fistula. Management of typical airway malacia is through manipulation of the PEEP, which is more common. In very severe instances, in distal airway malacia, helium or oxygen mixtures have been used. And some centers do perform iotapexic with significant tracheomalacia for specific surgical correction, but this is not commonly performed in this age group. The small airway disease, which microscopically do present with thickened epithelium and hypertrophy of the smooth muscles in the small airways. Sometimes these can respond to bronchodilators. However, there is a genetic variability in response, and this is not a routine use of bronchodilators. And inhaled and systemic steroids, again, these are not routinely recommended. There is no evidence that shows routine use of these medications help in either prevention of BPD or progression of BPD. However, studies have shown that short-term use of the systemic steroids have been helpful in during pulmonary exacerbations. And similarly with the bronchodilators too, they have been shown to improve lung compliance during short periods of this use. Mucolytics such as Dornier alpha has been used very occasionally when the concern has been very thick secretions that are not typically cleared using the bronchodilators. Then we have the parenchymal lung disease, which is often what we refer to when we look at the chest x-rays. Some of the medications that are used and shown to be effective are furosemide, thiazides, and spironolactone. However, routine use is not recommended, but during when there is evidence of pulmonary edema or low compliance of lung during ventilation, use of these diuretics have shown to improve the lung mechanics. But more importantly, in lung parenchymal disease, it is the ventilatory strategies that would be helpful. While we do use for preventing BPD very gentle ventilatory strategies such as low tidal volumes, around 4 to 6 ml per kilo, short inspiratory time. We use gentle PEEP as needed for lung recruitment, and the goal is to achieve the lowest FiO2 possible. We also aim for oxygen saturations between 88 to 92% and providing permissive hypercapnia, which works great while in the earlier period. But when we look at the pathology of more severe BPD, where we see heterogeneous lung disease, as we see in this picture, we have alveoli that are atelectatic, that have high resistance and low compliance. And then we have few normal alveoli or areas of lungs which have normal compliance and normal resistance. And then we have a few more where areas with high compliance and low resistance, which seems to be the overdistended, the hyperdense areas that we see on the X-rays. So when we use the low tidal volume and the gentle ventilation strategies, most of the ventilated gas enters those areas that have high compliance and low resistance, and hence it fails to recruit the atelectatic part of the lungs, and this leads to regional overdistension and more dead space, resulting in high PCO2 and also need for higher FiO2 because of VQ mismatch. So in these instances, having a strategy with higher tidal volume and lower inspiratory rate and optimal I times will give enough time for the ventilated gas to open up those parts of atelectatic or high resistant, low compliance lungs because of the slow rate that goes with this mode of ventilation, leading to optimal gas distribution and less atelectasis. So the recommendation is to use larger tidal volumes, anywhere between 10 to 12 ml, longer I time, typically around 0.6 seconds or longer. And if there's evidence of airway obstruction, using slower rates for better emptying, so there is no air stacking and hyperinflation, and manipulation of the PEEP. Now, this is a more complex issue, especially if there is evidence of tracheomalacia, like how do we optimize the PEEP? There are various ways, either through direct visualization under bronchoscopy. There are some centers that have used dynamic CT scan to see what's the optimal PEEP in these scenarios. Or something what we are doing in our center is we do optimization study based on the ventilatory, the flow volumes on the ventilators. So here in the ones there is an established BPD, we also recommend targeting oxygen saturations from 92 to 95%, moving away from the lower saturations, which can further stress the pulmonary vasculature. And higher PCO2s are associated with worse disease outcomes. So that is also, we are moving away from this permissive hypercapnia. And then comes the topic of tracheostomy as to when is this indicated. So once we have patients stabilized with severe BPD on the late BPD ventilatory settings, if there is consistent need for or sustained need for mechanical ventilation with high support, which we are unable to wean, that would be an indication for starting this discussion of tracheostomy in the group and the family. And also, if the patients are needing prolonged intubation resulting in distress or spells, that's another indicator that they might need a tracheostomy would be helpful. And tracheostomy in the setting of prolonged intubation would also help promote growth and developmental outcome, so that the baby can then participate more in the occupational and physiotherapies. But obviously, this is a complex and difficult decision and needs a multidisciplinary approach, especially in this era where nationwide there's a big shortage, and we experience in Hershey too, where although we do go the route of the tracheostomy with the aim to get our patients home earlier on, we have a big shortage of home nursing. So that kind of restricts the patient staying in the hospital longer, sometimes even weaning their ventilation and coming off of their ventilatory support while they are still in the hospital. So it's certainly a complex decision. So pulmonary hypertension or pulmonary vascular disease associated with BPD is more prevalent when the babies are have a lower gestational age compared to those that are born later on. And this incidence can vary anywhere from 25 to 40%. And the market pH in those less than 3 months of age is associated with pretty significant mortality, up to 40%, within the first 2 years of life. And if there is severe pH, this mortality can go up to 70% of this patient population. And something else that can worsen the comorbidities that can worsen BPD or pulmonary hypertension or swallow dysfunction, GE reflux, oral secretions, if there's evidence of aspiration, and increased upper airway secretions. And they can present with tachypnea or frequent desaturations, hypercarbia of poor weight gain, especially because this is not an aspiration event at one time and then the patient deteriorates, which also happens like we see in our neonatal ICU. But those with small amounts of microaspiration present with chronic symptoms such as tachypneas and frequent desats and poor weight gain, rather than one single episode of decompensation. The challenge with this is that diagnostic techniques lack sensitivities and specificities, and often we might need to repeat the studies. In very severe cases of aspiration and reflux, G-tubes with or without Nissen's fundoplication might be warranted. However, at our institutions, we have completely moved away from Nissen's fundoplication, and in very severe reflux and aspiration risk, we have often gone the route of the GJ tubes. Anti-reflux medications such as H2 blockers and PPIs have been used, and in very severe cases, gastric propulsive agents or post-pyloric feeds have been implemented. As you're all aware, nutrition is the key in terms of managing BPD because of their hypermetabolic state, increased work of breathing, growth suppression from chronic stress and inflammation. And if they're on chronic steroid or diuretic use, this becomes much more of a priority. While monitoring the nutrition, it's important to not just look at the weight, but look at the linear growth for the overall somatic performance of these patients. Typically, the caloric target is around 130 kilocalories per kilo per day, and we might need to increase this based on the patient's need. Protein needs ranges from 3.5 to 4.2 grams per kilo per day, along with all the other micronutrients need to be assessed on a regular basis. Which is where, given the complexity, there is need for diverse expertise. There is also a need for a focus group of providers who are familiar with the most updated literature, since this is continuously evolving field. And often it needs commitment to the care of this unique and challenging patient population, especially from the nursing standpoint. There is a need for standardization of practice where there is no frequent change from one week to the next in terms of the practice managing these patients is concerned, and continuity of care with the subspecialties from transitioning from inpatient to outpatient is key for successful outcomes. This is our multidisciplinary team at our institutions. So we have pulmonology, cardiology, neonatology. We have respiratory therapists. We have the NICU nurse managers. We have home ventilator nurse practitioner. We have pediatric radiologist. And we do round with our nutritionist, speech therapist, and ENT subspecialty once in 2 weeks to maintain the consistent core group, along with the on-service team to discuss our patients. And most importantly, we also have our families as part of our working group. So especially those with severe BPD needing tracheostomy, it is important to identify the outpatient once they get ready to discharge. I identify the outpatient primary care physicians or pulmonologist, or cardiologist, and have a seamless transition from inpatient to outpatient. For those who are not even on a ventilator, but also those on like low flow nasal cannula, our aim is to prevent significant changes few weeks before they get discharged to maintain stability so there is no weaning on their oxygen or tube feeds right before they get discharged home, and also to monitor for consistent weight gain. We often have a handoff to the PCP by a phone call. So there is a direct communication with the outpatient service team. And we do emphasize on growth, monitoring weight and length percentiles and optimizing calories, and also screen for comorbidities, especially in the setting of aspiration. Early intervention referrals to monitor the neurodevelopmental outcomes is recommended, and all the patients get it mandatory. There is infection precaution. We recommend seasonal RSV vaccination until they are 2 years of age, and then the annual flu shot. And referral to pulmonology, we recommend if there are infants with any degree of BPD, especially those who need home oxygen or on inhalers or need diuretics. We do try to standardize our care in terms of how we wean outpatient supplemental oxygen in our BPD group. These babies are assessed in the follow-up clinic every 2 to 4 weeks. We do have continuous pulse ox monitors on them until they are completely off of the supplemental oxygen. We do stepwise weaning of their oxygen, and first we try to wean them to room air during the daytime or during awake periods before we do the nighttime weaning. And if there is any significant history of pulmonary hypertension, we would like to do an overnight sleep study where possible, or a pulse oximetry study before we completely discontinue the oxygen at nighttime. And even after discontinuing while they're on room air, at least if they are closer to the winter months, we keep it through the winter months to use as needed for acute viral infections. So the long-term outcome for these babies, once they're off of oxygen, it doesn't necessarily mean they don't have BPD anymore. This is a lifespan disease. Studies have shown consistent or persistent pathology into adulthood. There are many studies looking at school-age children having obstructive lung disease and also sometimes restrictive or air trapping with dysynaptic lung growth. And there was this one study from Australia where they did a chest CT scan on a cohort of adults who were born premature. And 85% of them had emphysematous changes. Almost all of them had some structural changes on their CT scan, but 84% of them had emphysematous changes on their CT scan, irrespective of whether they were symptomatic or not. So this is something, the information that I typically share with families. There are also studies that show abnormal gas transfer or DLCO, other than just obstructive or restrictive airway diseases. Something else that we note in those adults who were born premature, there have been multiple studies, especially led by Dr. Karagoz, where there is evidence of pulmonary vascular disease in adults who were born prematurely. And this was driven by the number of days on the assisted ventilation in the absence of pH in the infancy. And these patients, the adults, were asymptomatic, but still the cardiac cath did show subclinical pH. And 2 of them did have clinical pH. So in summary, BPD is a growing condition with complex lung disease with varied phenotype and high morbidity. Focused clinical and research efforts are needed in management of BPD in conjunction with prevention of BPD. While there's been a lot of studies in preventing BPD, there is lack of that effort, or need for increased effort in managing BPD, as there is lack of evidence for a lot of these medications and management strategies. Need for identification of long-term sequelae in this high-risk group as they transition from childhood to the adulthood, because this is not just restricted to early childhood. This is a lifelong pathology. So how do we strategize for these patients to be followed closely even after their transition into the adulthood? Do we need a separate BPD clinic for these patients, just like the cancer survivor clinic? Do we need a BPD clinic that needs to span the lifetime for these patients for early identification of adult onset clinical symptoms? So with that, I'd like to thank you all for your time, and I can take any questions that you have.
Thank you very much for that wonderful presentation. If you have a question, please go ahead and raise your hand or unmute yourself. You can also place questions in the chat. Yes, Dr. Seidner?
Thank you, Sadaya. That was wonderful. One question I have is, and I know some of your research is looking forward, how do you see us predicting those that weren't obvious at the end of their neonatal course, but are still at high risk for adult pulmonary vascular disease? What kind of predictors do you think we'll have in 5 to 10 years?
Thank you. Great question. Right now, based on the previous studies, clinical studies, some of the predictors have been the number of days on the ventilator that these patients have been while in the NICU. But we need more robust clinical parameters that can help us predict some of the, there's been a lot of work in terms of endotyping these patients. My particular research area is looking at the microRNAs that can predict development of vascular disease, at least in the early childhood, but that is a potential for looking at the long term into adult patients, because there seems to be a multitude of, when we look at the pathophysiology, you have antenatal factors that can predispose to that, and we have perinatal. And also, we don't have much information what happens, what drives this vascular disease later on in life with BPD, right? Because they're already at high risk, but how does the, say, viral infections modulate this risk? How does exposure to cigarette smoke modulate this risk? So it's a very complex pathology, and I think there's a very big need for identifying these patients. And one way to do that is by establishing a pathway where we can follow these patients on a regular basis and collect all the data, build a database that can help us then study what are the drivers or what are the predictors of developing adult pulmonary vascular disease.
Yes, Dr. Gong, go ahead.
Oh, thank you. Thank you for that presentation. The Swedish studies on long-term follow-up have shown that babies who are diagnosed with BPD tend to die earlier. And they also have a lot of heart disease, which so we don't know what the cause is. It's probably the BPD and pulmonary hypertension. The challenge I see is that we have babies that we follow up to 5 years here. And once the babies are off oxygen, the parents tend to not want to go back to the pulmonary clinics for follow-up, and they tend to miss those appointments. And so I think that the feeling is once they're off oxygen, they're fine, which drives me nuts. But I think that we need to understand these kids on a long-term basis, and that they do need periodic evaluations because they do die much younger, and we have to figure that piece out. And so I applaud you for the work you're doing, and because we need to know that information. Thank you very much.
Yeah, thank you. Thank you for the comments. That is a challenge. That is a challenge. How do we educate our families and emphasize the importance of this long-term follow-up? So we start with that education right at the get-go when we start seeing them in the NICU. Even when I see the patients, like the first time I see them outpatient, my visits are sometimes an hour long, just because we spend so much time educating. And that, like you said, once they're off of oxygen, everything seems like, okay, we don't really, the kid has grown. And not just the parents, right? There are so many, even primary care, there is, we need more education to say, hey, this is not just an early childhood condition. We need long-term follow-ups. And even when they wean off of oxygen, we try to, do the same education. And that is one thing that we have started as part of our BPD program, is to follow them through until the adulthood. I still don't have anything. Hopefully we'll have, an adult pulmonologist who would be interested in BPD, but I think we need that pathway set in where we can follow them, even if not every year, at least every 2 to 3 years. So one thing that I tell the parents is we need to look at their lung function. So I need to see them at 5 years of age. And then we again follow them at, 3 years after that, at 8 years, and then at 10 years, where we try to collect all the data in terms of their lung function, one, to follow the patients, but also to build our database and collect the data points so we can educate ourselves going forward. How can we better define these phenotypes? What kind of like restrictive lung disease? Are they having obstructive pattern? Do they have airway reactivity? We don't have enough data to see what subset of these patients develop these different phenotypes. So there is definitely that lack of information. And we do talk about early death in this patient population, which, worries the parents. But I hope that also highlights the importance why we stress so much about this continued follow-up. And, we talk about annual flu shot, eliminating smoke exposure in these patients. But I think there's a lot that needs to be done. And I think there's also more data for the early death and cardiac disease, cardiovascular diseases, higher incidence of cardiovascular, is there's some evidence of high risk for these premature babies for metabolic syndrome, right? I mean, they are high risk for cholesterol abnormalities or hypercholesterolemia. They are high risk for obesity, diabetes. So they have this high risk for metabolic syndrome, which probably is due to some modulation of growth factors in this population, given their prematurity and early stress exposure. But there's not much information or data there either. So I think there's, as we see more and more premature infants who are now surviving into adulthood, we need more robust efforts to study these patients and maintain that long-term data collection.
Thank you. There's a question in the chat, then I'll go to Dr. McKernan, then Dr. Moreira. Dr. Wu, one of our intensivists, asks, how does your group help prepare caretakers of babies who are going home with tracheostomies in their care, and how to deal with emergencies?
Thank you. Great question. We are very fortunate to have a very robust home vent program. So this helps with our BPD program because we start seeing these patients at around 36 weeks with any kind of respiratory support. That's when we start seeing. Now, when we see those with severe BPD, those on mechanical, invasive mechanical ventilation, we see them more regularly, and we start having this, when we start having the discussion of tracheostomy, we have our home vent nurse practitioner be part of that. So we set up a relationship right from the get-go. And then we collaborate with our ENT who does the surgery, and we work together. Once they agree for the tracheostomy, we have a 6 weeks training program for these trach vent patients, where we need at least 2 care providers, being able to take care of the patient while we also look, and we need to have nursing at home, but we need at least 2 care providers who are adept at taking care of these babies. We have sim lab training for addressing various emergency situations at home. And once they're discharged home, so we have like a medical home like setting. So our home vent nurse practitioner is a key person where all these home vent patients with any concerns, they are reaching out, and we have another nurse practitioner who calls them within 2 to 3 days of being discharged home to kind of troubleshoot any concerns they have. We also have within a month of them discharging home, we see them in the clinic as well, and then we do a lot of telehealth visits with these patients who have issues with access. But we've had a very robust program, which is now almost 20 years old, and we are very fortunate to have a core group of providers that help run this program.
Dr. McKernan?
Thank you again for a wonderful presentation. And back to pulmonary hypertension, as you know, it's a determinant of long-term outcomes and mortality. And you mentioned how you wean the oxygen carefully, particularly in the presence of pulmonary hypertension. But I'm wondering, do you use other agents outpatient to manage your pulmonary hypertension, like bosentan or sildenafil? And if so, how do you coordinate weaning those agents as well on an outpatient basis?
Thank you. Excellent question. Again, I'm very blessed, I should say. I have this excellent cardiologist that when I started developing the program and I reached out to him, he's also director of the pulmonary hypertension program, and we work very closely together. So if there is a significant pulmonary hypertension, so the first line of management, I know that's another topic in itself. is to optimize the respiratory support, right, for pulmonary hypertension associated with BPD. And in spite of that, they continue to have signs of vascular disease. In conjunction with the cardiologist, we do start them on sildenafil. I mean, obviously ruling out other things such as, on the echocardiogram, if possible, rule out pulmonary vein stenosis. And if they have like a significant hemodynamically significant shunt, such as PD or ASD, that needs to be addressed. But if the patients are going home on the pulmonary vasodilators, then, or even if they don't need pulmonary vasodilator, but they have signs of PH, mild PH, we see them. We have a combined clinic, a multidisciplinary clinic, where we see those patients together. So we literally sit together, we review the echocardiograms together, we review how their growth, how their oxygen requirement is. So we try to, we don't, once the pulmonary hypertension is well controlled on the echocardiogram, we try to wean their oxygen first, not necessarily the vasodilators, to make sure they tolerate weaning the oxygen, since that is one of the pharmacotherapy for pulmonary hypertension. And we gradually wean the sildenafil if the patient has been stable for a number of months off of the respiratory support. So that is what we do, and it is usually a combined effort between me and my colleague, the cardiologist. And this also includes the diuretics. If they're on diuretics, we do very slow wean in those patients. Now, when it comes to bosantan or the second pulmonary vasodilators, typically if sildenafil is not enough and then the pulmonary hypertension is not well controlled, that's when we recommend a cardiac catheterization. So we obtain a cardiac catheterization to better delineate the vasoreactivity, rule out other abnormalities such as pulmonary vein stenosis before we start bosantan. And typically these kids, when they're sick enough, they're in the ICU, and that is where we do the bosantan, typically in the PICU, not as much in the neonatal ICU. So they go home on that. And again, the weaning process is very slow and, mostly driven by our cardiologist. But we work very closely together. If we are not able to see the patient together for whatever reason, we are constantly texting and discussing, okay, should we do this? So it is a combined effort.
Thank you for that answer, and thank you for pointing out pulmonary vein stenosis is a long-term issue as well. That's sometimes neonatologists aren't cognizant of that concern, and it can be hard to identify. But it can present in the NICU early on before they go home. So I think always being vigilant for the concerns about pulmonary vein stenosis is really important. Thank you for pointing that out.
Yeah, thank you.
Dr. Morera?
Hi, can you guys hear me?
Yes.
Okay, great. Rupa, thank you so much for the great work that you do. Very excited and interested in a lot of lines of just the clinical as well as some of the investigations that you're conducting. And so I have a two-pronged question. I'm more interested in some of the bioinformatic work that you're currently focused on. And can you tell me, the first question is, can you tell me how you are currently using some of the microRNA profiles to help potentially differentiate between those various phenotypes of BPD? Specifically, are you obtaining blood samples? When are you obtaining them? Or are these tracheal samples from that first week of life? And then secondly, are there specific signaling pathways that you think microRNAs are helping regulate right now that are critical in the lung development of these preterm infants?
Yeah, thank you. Excellent questions. Actually prepared slides for those two for the research part of it. But I'm excited to talk about it. So when I started our work, it was driven by, I didn't start as a researcher, but as a clinician during my NICU consults. Noticed how challenging it was to diagnose pH in this patient population. And my goal was to start looking at non-invasive biomarkers that can help delineate these babies with pulmonary hypertension from those who have BPD, because the symptoms overlap between the two, right? So it's kind of hard to tell who has PH and who don't. And while we do the echocardiogram, it is sometimes you don't get a good window, and sometimes if we don't specifically ask for pH parameters, they're not even mentioned, right, in the report, or they talk about, okay, good ventricular function, but I'm not looking for that. I want to know what the interventricular septum is doing. I want to know what the TRV is. So we don't get all that granular information. So my goal was to look at a non-invasive marker, and at that time we started looking at the tracheal aspirates. So we did a multi-omic, we did proteomics, we did microRNAs, we did transcriptomics, mRNAs in the tracheal aspirate to identify. So we compared two cohorts, those with BPD and PH, to see what delineated between the two phenotypes. So pulmonary vascular disease and without pulmonary vascular disease in the setting of the BPD. And we identified markers which, when we did the in silico predictive modeling, the downstream targets were VEGF, insulin, and particularly we were more focused on the microRNAs because they are the gene regulators, and modulated the mRNA translation phase. So when we focused on these microRNAs, we had pathways that were targeting PDGFA, angiopoietin-like protein 4, and TNF alpha among some of those markers. Now we are looking more in depth into the mechanistic pathways of these microRNAs, and in particular, MIR29A, it has been of interest. That seems to be upregulating some of these PDGF, the vascular growth factors, or actually downregulating the vascular growth factors in the pulmonary artery smooth muscle cells. And I'll be excited to share that information this afternoon.
Thank you. Looking forward to hearing more about that.
Thank you.
Any additional questions? Dr. Seidner did comment that Dr. Sadai will be discussing research at 11 o'clock as well in the pediatric conference room. I'm going to allow an awkward 10-second pause to see if any more questions come up. Okay, well, if there are no more questions, thank you again, Dr. Sadai, for that wonderful presentation, and have a safe journey home.
Thank you. Thank you for having me.